Hello and welcome to the Clinical Liver Disease Journal Club video series. CLD is an official digital learning publication of the AASLD. I'm Julius Wilder, Assistant Professor of Medicine and GI and Hepatology at Duke. I have the honor of speaking today with Dr. Brett Fortune and Dr. Alyson Kaplan, who will be presenting a really interesting article entitled Deficits in Advanced Care Planning for Patients with Decompressed Cirrhosis at Liver Transplant Centers. We'll begin with a very brief overview of the article and its content, and then we'll dive into some deeper discussion about what the article is about and really about its implications with respect to our practice today. And so thank you so much, Dr. Kaplan and Dr. Fortune, for taking the time to speak with us today. And I'll turn over to you, Dr. Kaplan, to present the article.
Thank you very much. I'm just going to share my screen here. So I'm Dr. Kaplan. You can call me Allie. I'm a second-year GI fellow at Weill Cornell, and I will be doing a transplant hepatology year at the Cornell-Columbia Combined Program starting in July 2022. And so this is a brief overview of the article, which is of particular interest to me. And we have some self-advertising here in the corner. This is my Twitter handle as well as Dr. Fortune's. So this article was written by Arpan Patel and his research group. As Dr. Wilder mentioned, it's entitled Deficits in Advanced Care Planning for Patients with Decompensated Cirrhosis at Liver Transplant Centers. And so we all very well know that cirrhosis is increasing significantly in the US. And we also know that cirrhosis has increased mortality compared to many other diseases that we think about, like heart failure, and certain cancers, certain malignancies. However, patients with cirrhosis often receive more burdensome care, especially at the end of their life. And so if you look at the data, more than half of patients with cirrhosis are mechanically ventilated and greater than 15% receive hemodialysis during their terminal hospitalizations. In addition, patients with cirrhosis are less likely to die at home and more likely to die in inpatient facilities, nursing homes, and long-term care facilities. So we know that liver transplant is life-saving, but unfortunately it's not an option for many. One, because there's a shortage of organs, and two, because many people are not transplant candidates. Despite all of this, advanced care planning conversations, which is a conversation where patients share their values, goals, preferences in the context of their prognosis, it's lower in cirrhosis than any other disease processes. And so Dr. Patel and his research group wanted to understand why. So the aim of their study was to describe the experience of advanced care planning in patients with decompensated cirrhosis at 3 liver transplant centers. So they used qualitative methods, which we'll discuss in greater detail. Like I said, it was across 3 different transplant centers. And there was certain eligibility criteria for patients. So adults greater than age 18, a diagnosis of cirrhosis, greater 1 or greater portal hypertension related complications. And these included ascites, variceal hemorrhage, or hepatic encephalopathy, and a MELD score at enrollment or prior to enrollment of 15 or greater. And they made sure to include patients that were at all stages of their liver disease. So patients who were too early for transplant evaluation, so they weren't sick enough yet, patients that were currently undergoing evaluation for transplant, waitlisted patients for transplant, and then not waitlisted patients for transplant because of contraindications such as age, comorbid conditions, psychological barriers, or substance use. And then exclusions included HCC, given the advanced care planning conversations in patients with concurrent malignancies are often quite different, and patients who had hepatic encephalopathy, given that they would not be able to participate in interviews. And then in addition to patients, the study group also interviewed clinicians, and these were the healthcare providers responsible for providing care, including transplant hepatologists, transplant and hepatobiliary surgeons, transplant coordinators, and social workers. So with their qualitative methods, basically it consists of an interview guide, which an example is presented here. And an interview guide has leading questions that are followed by particular probes. So if you can see here, there's a leading question. Can you tell me about how you became diagnosed with cirrhosis and what the experience was like. And then you can follow that up with further probes. And so there were 88 face-to-face semi-structured interviews, and these were conducted between July 2017 and May 2018. Interviews were audio recorded, transcribed, and then imported into NVivo for analysis. And basically an analysis in qualitative work is to develop a code book, which uses codes corresponding to major elements of advanced care planning. And then themes are developed based on this coding and compared to generate a final set of themes that represented the range of ACP experiences. So what were their results? So just some descriptive results. So they ended up with 42 patients and 46 clinicians. The mean age of their patients was around 58, 33% were female. The mean MELD was 15.9. And then, as you remember, I mentioned that they tried to recruit patients from all stages of their liver disease, and they pretty evenly did that. So 26% waitlisted, 21% undergoing eval, 24% too early, and 29% not candidates. And then here you can see the 46 clinicians that were represented from a wide variety of areas, including hepatologists, transplant coordinators, hepatovalvular surgeons, social workers, NPs, and critical care physicians. So what are the themes that they identified? So these are the 5 themes. So the first theme, most patient consideration of values, goals, and preferences occurred outside outpatient visits. So patients were comfortable talking about their preferences, but noted that with the exception of their visits with social workers, conversations did not usually take place with clinicians themselves in the office. The second theme was that optimistic attitudes from transplant teams hindered the discussions about dying. So patients often expressed frustrations about being in limbo or particular concerns about dying, but rather than exploring these issues, clinicians more often focused on optimistic outcomes, such as getting a liver or not needing a liver because of improvement. So the third theme was that clinicians primarily discussed death as a strategy for encouraging behavioral change. And I think that that's pretty self-explanatory. Often, clinicians would say, if you don't stop drinking, you might die or you might get sicker. The fourth theme is that transplant teams avoided discussing non-aggressive treatment options with patients. And this is pretty consistent with theme 2, in that clinicians often had patients choose between the goal of pursuing transplant, so that optimistic goal, and choose between that and then the goal of pursuing comfort-focused care. And then the last theme was that surrogate decision makers were unprepared for end-of-life decision making. So just in discussion, so there definitely were some deficits in advanced care planning that were identified. There were infrequent conversations, a focus on transplant, deferral of conversations until very late, making it difficult for surrogate decision makers. And so the authors identify that there are multiple opportunities where clinicians may be able to explore values and goals in more detail. So given that cirrhosis has an uncertain prognosis, this is a perfect opportunity to explore patients' wishes and values. Clinicians can counsel patients on the trade-offs required in continuing aggressive care, and they can help to elicit a patient's values and goals in preparation for less fortunate outcomes. And then when patients report contradictory preferences, this is another opportunity to explore their goals further. Instead of making them choose between pursuing transplant and pursuing comfort care, clinicians can choose to explore these contradictory preferences and have a nuanced conversation about them. So there are some limitations of the study. There were no perspectives from palliative care physicians themselves or primary care physicians. And the authors cannot comment on the frequency of behaviors given that the methodology was qualitative. And then lastly, as with most research that's done at particular transplant centers, this might not be generalizable to all transplant centers. So in conclusion, inadequate advanced care planning throughout illness until the end of life was present in patients with cirrhosis. Clinicians infrequently engage patients in advanced care planning and in conversations about values, goals, and preferences. And some of this, especially conversations that are happening very late in the disease process, may explain aggressive life-sustaining treatment in cirrhosis. Okay, I'm going to stop sharing, and then I think we can begin our discussion.
Great, thank you so much, Dr. Kaplan, for that great overview of a really interesting article that is, in some respects, I would argue, in hepatology is somewhat unique. I'd say unique not only with respect to the topic, a topic that needs to be discussed, that's not, at the forefront of our conversations in the way it should be, but also methodologies that are not typically used in hepatology. And so really excited to have this conversation with the both of you. Dr. Fortune, and I asked you this question because, you're old like I am. Dr. Kaplan hasn't been around hepatology quite as long. And really, and given how old you are, like me, how do you feel attitudes towards palliative care in patients with end-stage liver disease has changed over the last decade or so? Do you feel transplant centers are more open to it? Have you noticed an increase in the number of transplant centers adopting palliative care discussions as a part, building it into, really embedding it into their programs at the time of transplant evaluation?
Yes. First, thank you for inviting us, and very excited to highlight this topic. And thank you, Dr. Kaplan, for a wonderful presentation of the article. Yes, listen, I believe over the last decade, I believe there's definitely been increased recognition and exposure to understanding palliative care, advanced care planning in the transplant setting. However, I think implementation and culture change still is lagging, which is often seen in many culture changes. And so I believe a lot of these deficits that were nicely highlighted still remain true even to this day nationally. And I think what's really important is with the increasing library of literature that supports its benefit, as well as having active stakeholders that continue to voice its importance, will continue to turn heads and get people more aware and recognize that we need to do something in order to make this more patient-centered.
Sure. You raised an excellent point, right? This idea of culture change and how we view management of our patients with end-stage liver disease. Can you briefly just, and certainly Dr. Kaplan weigh in as well, what type of culture change do you think needs to happen as we think about how we do that? Or maybe even what do you think of some of the barriers to that culture change occurring around how we view palliative care and end-of-life discussions with our liver patients?
Well, I think it gets to some of the gaps that were identified, and getting to your earlier point about, this is a very unique situation in the setting of liver disease, because in advanced liver disease, we don't have bridges without transplantation, such as dialysis for kidney transplant, or now ventricular assist device for heart failure. So we are a unique aspect where, because we don't have these successful quality enhancing bridges, it really magnifies the importance of doing so and trying to address as what are patient perspectives of life, and not, ongoing single highway directions of just, it's either transplant or bust. I think we have to rethink things. And so it's really helpful. And, I think with the upcoming generation of hepatologists and surgeons are aware of that, and will hopefully continue to promote that. So us old people, I used in quotes because I'm still considered young, we'll continue to see how important that is to do that culture change.
You highlighted this idea of them filling this gap of knowledge, and they fill it in a unique way. They leveraged a unique methodology that we don't often use in hepatology. We see a lot of the large database analyses. We even see emerging use of things like AI and whatnot. But they, use qualitative analyses in this, frequently used in hepatology. Could you guys speak to that methodology and why you think it is particularly relevant in this setting to understand this topic?
Yeah, so I can address that. So, it's really interesting. I think qualitative methods are up and coming. I'm actually in a master's of epidemiology and health services research through Cornell right now. And we actually had an entire class that was dedicated to qualitative methods and learning how to do it. And so I think people are starting to think of it, as much as they're thinking about database research. And so, like, in my opinion, I think qualitative research is used in multiple settings, but really in two. So one is when you need to really gain a deeper understanding of a problem by going directly to the source in their like more natural habitat. And then another is to study a topic that has been rarely studied in hopes of generating hypotheses from just having discussions with patients. And I think both of those things are applicable to this particular topic, where you really want to gain a deeper understanding of what patients believe about advanced care planning. And it's also a topic that has not really been explored. And so doing this qualitative research will help to generate hypotheses or ideas for prospective research. We could look at databases and determine how many palliative care consults a patient received or the cost associated with that, but it doesn't really help us to determine why. Why is advanced care planning not well established in hepatology? Why do patients think it's important? What are the barriers for clinicians? And so really getting down to the source, I think, is really important.
That's a great point. I agree with you. I think this qualitative work really allows you to contextualize the issues in the way, right? It's that next step of, addressing it or creating interventions, you can really do something that's probably going to be more impactful and sustainable, right? If you're able to really properly contextualize the issue at its base. It's great you're taking that class. We look forward to your future talking about your journal article next time we talk about this subject. Let's talk a little bit more specifically about the article. There were a number of really interesting themes that came out of the work that they did. The theme one, for instance, they identified that patients express their values, goals, preferences outside outpatient visits. Why do you think that occurs? And are there barriers, you think, that hinder the open expression of their true values and goals and preferences in the setting of the patient visit?
Yeah, I think that's a really good question. I think it is related to a lot of the other themes that came up as part of the study. I think, in very limited appointment times that we have with our patients, and you guys have more experience with that, especially with complicated patients with decompensated cirrhosis, if providers are already a little bit uncomfortable or it's not natural for them to discuss advanced care planning, and they're more focused on these optimistic or black and white outcomes, it then becomes very difficult to have these conversations in that limited period of time. And also, patients, as they expressed in this study, may have conflicting values, they may have things they want to bring up, but they may not feel comfortable doing that if they don't sense that, that kind of conversation is welcome. And so I think, some of the things that, I addressed in the discussion of this article, using uncertainty of prognosis as an opportunity to address a patient's values and goals is a really good time point to sort of have that conversation with patients in the office.
Yeah, that's a great point. And so theme two, to your point around sort of their expectations, how they sort of go into that visit, describes this overly optimistic transplant team, right, as an obstacle to discussion about these issues in patients with end-stage liver disease. What factors do you all think drive this overly optimistic viewpoint? Some of that culture you were speaking to earlier on, Brett, are there unseen or not fully researched incentives that drives this optimistic viewpoint?
I think this is a great, it's something that we obviously expected to find, and it's great to see this kind of illustrated more objectively, but it's this ongoing goal in transplant where we're basically, glass half full, full court press, and make it happen. And trying to provide a goal of hope in a desperate situation, because we have this perception that if we take hope away, that we cause more harm than good. And I think there's always been this culture. It's like, we don't quit until the patient's transplanted. Even when we know, we look at the data, that's really just the top of the iceberg, and the rest of the iceberg, that 95% of people that never make it to transplant, we just don't address their needs adequately. And I think I'm hopeful that this article and other growing literature will continue to highlight the importance of us kind of changing our paradigm here and being able to address those goals, but still maintaining the positivity of both managing their liver disease and in the hope of transplant, but addressing, you know, their perception and goals of quality of life from earlier stages, I think is the other key point.
Yeah, I agree with you 100%. I talk to my patients about a positive realism about what we're dealing with right now.
Absolutely.
You know,
it's a balance of positive thinking and realistic thinking. And if anything, I think COVID pandemic has really emphasized that importance.
Great point. And so when you think about that, you know, Therapy 3 spoke to this idea of this sort of not so subtle tactic used by clinicians to sort of change their behavior, our patients' behaviors. You know, statements described aren't untrue. Increasing death due to ongoing drinking. Time is short without liver transplant. But certainly can be done better. You know, we're trying to sort of motivate our patients, make them understand those next steps. How do you suggest these conversations go? Are there better tactics that we can use as opposed to scaring them about death? How do you do it in your practice?
Yeah, I think this was a fantastic theme because it's clearly true, and
yeah.
I think we can all universally say we're guilty of this.
Yeah.
Because we only see patient factors and try to use guilt to try to change behavior. And I think we're all guilty of this and the implicit biases of, these kind of things, but we only do it when it's particularly beneficial for our goals.
Right.
And we don't take account of the other patient factors that may have driven them to this situation, whether it's continued drinking due to uncontrolled depression or financial factors or other things that we often defer to our other psychosocial team members to address. And so it is important to not villainize these patients and be more considerate of the other factors that are maybe unmeasured, and how we continue to be more mindful and aim for tactics that may be, as opposed to blaming blame, to try to rationalize on our approach where, well, there are a couple of try to depersonalize it, make it less personal, try to make it more as kind of a case example where we have certain pathways and these pathways lead to different outcomes. So we're kind of taking the patient out of that blame game and making it more as they can be part of the team and making those decisions. And it also allows us an opportunity, again, to focus on their goals and kind of the other highlights that we've already brought up and we'll continue to bring up. And so this is kind of that opportunity to do so. So yeah, it's a very kind of awakening comment from this paper.
Yeah, and I think a great example, right, of the kind of information you only get when you do this kind of research, right? When you're only going to get that kind of insight by doing qualitative work. And along those same lines, they identified in theme 4 this interesting cultural or sort of personality trait among the transplant teams, where we're avoiding discussing these sort of non-aggressive therapies. Do you think harm is occurring to our patients in the setting of this, like discussions occurring too late or after hospitalizations, increased suffering, time away from family, preferences, those kind of things? How do you sort of approach that, and how do you think we're hurting our patients by not having these conversations?
Yeah, so, I think harm is probably a harsh word, but I do think that, I do think that the study shows us that, patients and their caregivers, which we'll get to, talking about their caregivers, I'm sure in a second, but both of them prefer to have these discussions earlier in order to help aid in decision-making about the pursuit of aggressive therapies. So, I think understandable that we want every patient to try to get to liver transplant, but given that we know that this isn't reality, if we could have these conversations earlier, I think patients will have a better understanding of their prognosis and trajectory to help them make these decisions and maybe avoid, those many hospitalizations that occur at the end of life, or the intubations that occur on the terminal hospitalization or the dialysis. If both the patients and their caregivers really understood what the trajectory was. And that changes too. So, having conversations every now and then about, we were really hoping to get you to transplant, but now you have this contraindication. So, we have to take you off the transplant list, and what that means, I think is really important as well.
So that's a great point. And so when thinking about it, you kind of brought up this idea of the surrogate decision maker, caregiver, and the decisions often that they have to make, oftentimes by themselves, depending upon their loved one and how well they're doing. You see, I guess you would argue that having those discussions earlier is an important piece to sort of mitigating the effect on caregivers of these end of life decisions. Any other things you all can think about that we should be doing as providers, or how do you engage in those discussions with with your patients and their caregivers earlier on?
Yeah, I think I have a particular interest in caregiver burden, and I think that often caregivers are the ones that really, really suffer when their loved ones are at the end of life. Often, a lot of times the patients are encephalopathic or intubated, and their caregivers are watching them, not really having fully understood what was going to happen at the end of their life. And like you said, I think having these conversations earlier and including caregivers in these conversations is really the most important thing. It's been a little bit challenging with COVID. I'm not sure how it was at Duke, but here, we were often limited in who could come to appointments, given they were doing, extensive clinic appointment workup, travel and temperature taking and all of that. So it was actually quite hard to have caregivers present. But it's something that, an extra video visit where you're actually, involving the caregiver, maybe even seeing into their home and what their home situation is, and how chaotic or peaceful that is, and what would it look like if a patient wanted to be on home hospice? Would the caregiver be able to take care of that patient based on what's going on at home? And so just involving them in as many of the conversations as the patient feels comfortable with, I think is really important. I don't know if you have anything to add, Dr. Fortune.
No, I think one of the future directions for this work, as well as future works, is to involve the caregiver in this process. And I think as we look at complications of cirrhosis, advanced liver disease, and as we know, a lot of patients don't have assigned caregivers or even think to even have caregivers. I think bringing that up even before all these things occur, as soon as we have physician interaction with patients, is going to be critical to bring this up, and definitely in the early stages of a transplant evaluation. So that's an ongoing.
If we begin having conversations with our patients and engaging caregivers after they already have some decompensation, then that ship's already sailed, right? I mean, that I think you're absolutely correct. That needs to be a part of that conversation early on once we've identified cirrhosis, because we know we get transplantation, just management of our patients from day to day, from month to month, year to year. If they have a person that's with them at those appointments, supporting them, that they do better with their diet, they do better with their screening, and so you're absolutely correct that it makes total sense in that setting to engage them earlier on in this kind of conversation as well. You all have talked about some really interesting things to consider, quite frankly, broadly, in terms of how we manage our patients with end-stage liver disease. And again, Brett, you, I think, appropriately raised this idea of changing the culture. And a lot of that begins with how we address structure within our transplant centers, right? And so when you think about, for instance, transplant center certification, do you think we consider at some point in time in the near future requiring certification with respect to palliative care providers as part of that structure within our transplant centers?
So I think it's a great question. And I do think more education on the process in the evaluation is probably something we need to address. I think requirement may be a little bit too soon because we still haven't honed in on how to properly implement the delivery of advanced care planning. So for the masses. And so before we start suggesting requirements for certification, not to mention there's still a very large deficit in workforce of palliative care. So we would need a much larger workforce as well as access and financial models, because we need to be able to reimburse these providers for their, and so ongoing bundle payments, et cetera, are necessary before we start asking for requirements. But I do believe it highlights the need for increasing education in the process, not only for the care team, but also for the patients and the caregivers, like we said earlier, earlier in the game, as soon as possible, and really address those best case, worst case scenarios. Since although we aim for transplant as much as possible, we need to also prepare for the possibility of it not happening. And I think I definitely can admit that I need to become more consistent at thinking those worst case scenarios too, and the timing and when to do this. And obviously, this sounds like we have 3 to 4 hours per visit here to go over all these things. So how to effectively do it in a time efficient manner is still something we need to look into. And not put it all on our psychosocial teams, who are clearly overwhelmed with ongoing burden themselves. So more investigation with bright young minds to look into this and how to achieve this in the 21st century of medicine.
Yeah,
both the pros and cons.
I will say, yeah. So I'm going to ask you things, because you all have made a number of really interesting recommendations. If you're going to think about what you might prioritize, as next steps in research, for this specific topic, so that we can get to a point here, as you described, where we can make the type of, recommendations for our transplant centers to really implement positive change in this area. What kind of research, what are the things we should be prioritizing in the next steps in this area, in this field?
Yeah, so I think, starting off with more qualitative work is really important. Now maybe we have some sense of why, but maybe we can ask more from patients and their caregivers about who should be delivering this. Is it something that's better to be provided by their hepatologist with some maybe a small amount of training, or do they prefer it coming from someone who's trained in palliative care? Or does it come from social workers who are devoted to this cause, not to add to the burden of what social workers already manage? And so understanding from patients and their caregivers, more about how they see this being implemented, I think would be a very important first step.
Yeah, and to add to that, I think, definitely increase in qualitative work, but also we can look at expanding this to a mixed methods approach, where then we can add those metrics that we're all used to of those outcomes and everything, and pairing it up with these qualitative items. Something that I was really taken by was Jessica Mellinger talking about mixed methods in alcohol use disorder and alcohol liver disease. And I think this is another perfect example that mixed methods approach can really expand. And then that would help with the buy-in and culture change, because that we're all used to following metrics and outcomes. But if we can show that there are strong associations and improvements by these different modalities, then I think that will really help move the needle in the right direction.
Yeah, that idea of evidence-based quality intervention, right? That's how you really begin to move thing forward and have a significant impact. That's a great point. Well, thank you all so much for this wonderful discussion on a very, very interesting, impactful, and quite frankly, important article. On behalf of all of the CLD team, we hope that all of you watching really got something out of this and enjoy this. We thank you so much, Dr. Kaplan and Dr. Fortune, for your time. For more information about this and other interesting topics in liver disease, please visit www.cldlearning.com. And we thank you again for watching.